Jenny Berger, and I am doing my third validation, which is the assessment of the cardiovascular and the abdomen. And with me today I have Kenny. Do I have your permission to be my patient today? And these are the tools that I'm going to be using right here for my exam. We need to do a 360 of the room, the floor and the ceiling. First thing that we're going to be assessing are the 6 precordial points. So we are going to first do the inspection. We will be inspecting for any pulsations and activities. The precordial points that we're going to be assessing. We have the aortic, which is the second right intercostal space. We have the pulmonic, which is the left second intercostal space. We have Erb's point, which is the third intercostal space on the left. We have the tricuspid, which is the fourth intercostal space on the left. We have the mitral, which is the fifth intercostal space, and at the midclavicular line. And lastly, we have the epigastric, which is just below the xiphoid process to the left. As we palpate each of these areas, we would be looking for any thrills or pulsations. We would also be looking at the apical impulse, which is right down here at the fifth intercostal space, at the midclavicular line. As you're feeling for this, it should be about the size of a quarter. If we've noticed that there's any enlargement there, we would think about an enlarged heart, if there's any lateral displacement as well. The next thing that we are going to talk about would be the heart sounds. So in certain areas you hear the heart sounds better. So S1 is best heard at the apex, the mitral area. S2 is best heard at the base, at the aortic precordial point. S3, S4 are both heard at the apex in the left lateral decubiti position. Split S1 is best heard in the tricuspid area. Split S2 is heard best over the pulmonic area, and this is the one that can vary with any inspiration. Mitral valve prolapse is also heard at the apex in the left decubiti position. Heart murmurs. So you have the mitral regurgitation and the aortic stenosis, and there are two tests that we use when we are looking for the heart murmurs. You can assess by the Valsalva's maneuver, and you can also assess using the squat test. So if you are using the squat test, you have the patient bend down, and as you're bending down with them, you're going to listen over the apex area, and if the click goes away or if it decreases, it's probable mitral valve prolapse. What we're going to do today, if you could just lay down for me, is the Valsalva. Yeah, is the Valsalva's maneuver. So what I'm going to do is I'm going to place my hand on the abdomen, and I'm going to be listening in the mitral area. I'm going to lean across here. And as I push down, I'm going to ask him to hold your breath and bear down for me.
Hold my breath.
And bear down. And what I would be listening for is if the sound got louder, that would be probable mitral valve prolapse. If the sound decreases, it's probable aortic stenosis. But you're not, I didn't hear any changes for you, so you're fine. Could you sit up for me? So the next thing that we're going to be doing, actually I'm going to have you sit back and lay back down, but and lay back down. We are going to be auscultating, and when we do that, we are going to be using the diaphragm and also the bell. So what I'm going to do is I'm going to listen to the different areas, the precordial areas that I was pointing to before. I'm going to be listening with my stethoscope. So we're going to use the, well, Kenny is laying down in the supine position. We're going to be using the diaphragm of the stethoscope, and we're going to be going over all 6 points. there's the, we had aortic, we had pulmonic, we had Erb's point, we have tricuspid, the mitral, and the epigastric. Now we are going to use the bell, and we are going to listen over the apex. Okay, can you turn on your side for me?
More?
Yeah, that's fine. Okay, and then I need you to sit up for me. And I'm going to, when we're ready, I'm going to ask you to take a deep breath in, exhale it, and then hold it. And what we're going to do is we are going to listen with the diaphragm down the left lateral border. And this is going to, you can also hear sounds that will let you know if there's an aortic stenosis. So I'm going to ask you again.
And hold my breath after I let it out.
And then lean forward for me.
Lean forward. All in one. Yep. I see one right now.
Take it a deep breath in.
And then out.
Exhale, and then hold your breath for me. Thank you. You can breathe. Okay. You could lay down for me?
On my back.
Yes. What we're going to be doing here is we are going to be auscultating the carotid arteries. So there's going to be 3 places that I'm going to listen here. I'm going to have you turn your head and...
There's the main one.
Yes. You're going to turn your head and hold your breath for me.
Right.
And there's 3 places, and we're going to be listening with the bell.
So, don't hold my breath.
Go ahead and hold it. Good. Good, thank you. And we're going to flip around. Do the same thing. So take a deep breath in and then hold it. Good. Good, thank you. We'll just continue to lay down. We are also going to, his carotid arteries sound fine. We are also going to be assessing brachial, radial, abdominal, the aorta. So I'm just going to listen as we're going here. Can I have your arms down? Just hold them down for me.
Yep.
Aortic, renal, iliac, and femoral, which I'm not going to do, but we would be assessing right here for the femoral arteries. Thank you. Okay.
That's it.
We also are going, you can just say, Steve,
yep.
lay down for me. We are also going to be assessing pulses. Pulses are graded 0 to 4 plus. 0 would be absent, 4 would be bounding, 1 would be diminished. We are looking for 2, which is your brisk or expected. They can also be graded with a plus. So we're going to be assessing, and you always are going to be assessing that they're equal bilaterally. We are assessing for radial and femoral, which I'm not going to do. Can you slide? I know this is a little bit. I need your back of your knees. So yeah, just slide for me. Perfect. And I need you to bend your knees for me. That's fine. So this is the popliteal. We have the posterior tibialis. I need to take your shoes off. and the dorsalis pedis. So what we were going to be assessing for is that they're equal. His are fine, you're a 2+, so you are good. We're also going to be assessing for peripheral edema, and how we do that is we're going to assess on the foot. We would be looking for any type of pitting edema. There's 4 different types of edema. We have dependent pitting, anasarca, which is the generalized edema. We have cerebral, which is brain, and we have pulmonary, which is lung. It is measured, you check on the dorsum of the foot, you check on the medial malleolus, and also on the shin. And as if it's edematous, you just keep working your way up. We also assess for skin temperature on all the extremities, the upper and lower, so we would be assessing to make sure it's warm and dry. We would also be looking for checking for skin turgor, so make sure there's no tenning. That would be on the upper and the lower extremities. And we would also be looking for capillary refill. So we want to see that the refill is within 3 seconds. So we do that on upper and lower extremities.
Is that the color?
Yes, it is. Okay. So on the abdominal area, for the abdominal assessment, we are going to be inspecting, and as we do that, I'm just looking at your belly now, you don't do anything. We're looking for scars, any nevi, any striae, masses, any pulsations, anything that shouldn't be there, especially the pulsations for the AAA area. We want to make sure that we're really looking for that. The order of assessment is a little bit different here. After inspection, we will auscultate. So what I'm going to do is auscultate the belly for bowel sounds. What we're looking for is normal bowel sounds, which are between 5 and 30 per minute. If it were more than 30 per minute, we would say that they were hyperactive. If it was less than 5 per minute, we would say that it was hypoactive. Baborgamy is the audible growling. When you hear your belly growl from across the room, that's the word for it. And absent bowel sounds are when you can't hear bowel sounds after you've assessed the quadrants for 5 minutes. That's what you need to determine that. So what I'm going to do is just listen to your belly. You have normal bowel sounds. So after we've assessed for the bowel sounds, we've auscultated that. The next thing that we are going to do is we are going to auscultate for any type of a friction rub. You can have friction rubs over the liver. You can have friction rubs over the spleen. If you have a friction rub over the liver, it's going to be, well, over the liver and the spleen, it's both going to be a grating sound, and it's going to clue us in that there's some inflammation. Over the spleen, it can result from a splenic infarct. Possible causes, if it were over the liver, could be chlamydia, gonorrhea, liver biopsy, liver failure, or liver disease, or tumors. So I'm going to take a listen for friction rub. No grating sounds. I think that you're good. If the next thing that we're going to, if you had a friction rub, if there's a bruit that you have over a friction rub, you would suspect a carcinoma, a liver carcinoma. The next thing that we're going to assess for auscultation of the abdomen is for the venous hum. This is going to be a soft systolic, and it's rare. It can happen over the liver, the epigastric, or the umbilical areas. And this is going to give you a clue that there's increased collateral circulation, and it can clue you in that there could be hepatic cirrhosis. So that would be over the epigastric, the umbilical, and the liver. Belly. Okay, I don't hear any type of a hum, so That's good. The next thing that we are going to be assessing for is we're going to be percussing all areas of the belly. We are looking for dullness over the liver. We are looking for tympany over the rest of the belly because most of it's going to be filled with gases. So as we're, you can really hear that, huh?
Maybe the way I'm laying.
Well, actually, you can hear it. Listen. Do you hear that?
Yeah. What is that?
That's tympany. So that sound is tympany. So that's what the normal sound. But as soon as it turns dull there, that's over your liver. So anytime that it turns dull, it's going to be over an organ. So, so we did hear tympany over the belly, and it did become dull over over the liver. The next thing that we are going to be looking at after we had percussed, so we're done the percussion, we found that to be normal. The next thing that we're going to be doing is we percussed, we got tympany. Oh, we need to assess for palpation. So we are going to palpate the liver, and for any of the first we start lightly and we palpate lightly going along the path of the colon. So we're going to start here. Then do you have any pain or tenderness? The tickle?
We're gonna fart out.
Okay, so then you go deeper, and what you're looking for here is any kind of masses, anything that is painful. That's going to be an abnormal finding. If you see any type of a pulsation for the abdominal aorta, you would not palpate that. That's an emergency, and you would have that assessed. So if you see a pulsation. Okay, so we have the palpation is done. The next thing that we're going to assess for is for size of the organs. So we are going to be looking for the size of the liver and for the size of the spleen. And as we are going to assess that, we're going to come down the line here, and we are going to be looking for hepatomegalia, and that is going to be, we're going to be going up and looking for the change in the sound, which is right there. And then as you come down here, you're going to be measuring again, and it should be 4 to 8 inches or 4 to 8 centimeters, 4 to 8 centimeters at the midclavicular line. It should be 4 to 8 centimeters mid-sternally. It should be 6 to 12 at the midclavicular line. As you assess for the spleen, normally you cannot feel the spleen. If you can feel it, there's enlargement there. The spleen lies against the diaphragm between the 10th, 11th, and 9th, 10th, and 11th intercostal spaces. You should not be able to palpate that. If you do, there's going to be an enlargement. And I don't feel anything. Okay. The next thing that we're going to be looking at is, you can sit up for me. The next thing that we're going to be looking at is, let's see, we palpated. We are going to, oh, I'm sorry, you have to lie down again.
Yep.
We need to check for the abdominal reflexes. So what this is going to do, the upper is going to engage T 8, 9, and 10, and what we're looking for, and the bottom is going to engage T 10, 11, 12. So what we're looking for is the belly to move toward the stimulus. So as I'm bringing this in, should shift toward the stimulus. If this reflex was absent, we would think of somebody who has any nerve disorders and just is not any central or peripheral nerve disorders. Okay, so we did the reflex. The next thing that we are going to assess for is palpated for organomegalia. We so for the we're down to our testing of any special tests, which are going to be looking for appendicitis and for gallbladder disease. And I'm sorry, you're going to have to lay back down for me for this. So the first test that we would do, can you slide back a little bit?
This way?
Yeah.
Yep.
Is the SOS sign. So if we suspected somebody had appendicitis, we would be looking to just give us some signs with these special tests. So what I'm going to ask you to do is lift your leg. I'm going to put some pressure here. And as I'm doing that, if there were pain, this engages the psoas muscle. And if there was appendicitis, the person would have pain. The next thing, so that would be the psoas sign. His is negative. If there were pain, it would be positive. The next thing that we have is the obturator. And we're going to ask, can you just flex for me? And we're going to just leave this loose. And I'm going to rotate your hip. Just let me rotate it. And if there were any, we're going to flex that. And if there's any pain there, we would, that would also be a positive sign of appendicitis. We have rebound tenderness. So what we do is we push near the umbilicus and we release quickly. And if there was pain, we would be asking, is the pain when I'm pushing down or is the pain when I'm releasing? The next thing that we have is Robsing sign, and that is when we push down on the left lower quadrant of the abdomen and we release it quickly. And if the if the person experienced pain on the right side of the abdomen when we're pushing on the left side, that would be a positive sign. And you could also think of that appendicitis would be likely. The last thing that we're going to be assessing for would be for the gallbladder, and that would be for Murphy's sign. And what we're looking for is you're going to hook your thumb, and you push down near the gallbladder, and what you're looking for, it's underneath the costal margin here, and there would be a quick, abrupt stoppage of breathing, which could be a positive sign for gallbladder. And I think that is for all of the testing. If you could please do the 360 of the room again, and I think that concludes the exam. Sorry, my nose started to run.
My legs are just sort of